Hi everyone. Sorry, some technical difficulties. So today I'm going to be talking about Addison's disease. It's related to our endocrine system. So my name is Michaela Portelli. I'm a Sheridan College nursing student. My student number is 991817084. I'll include it on the PowerPoint as well. Oh, I'm opposite. Okay. Just a little bit of figuring out to do. So, like I said, we're going to be talking about Addison's today. So, hi, welcome. I have Garfield here. That's going to be helping me present as well. So, like I said, today we're going to be talking about Addison's disease, which is one of two of the main endocrine diseases that we really hear about. I think what we hear more in nursing is Graves' disease, but we're going to talk about the complete opposite. We're going to talk about Addison's disease. Saw earlier, it's an increase in our blood potassium level and a major decrease in our sodium, and our blood glucose, and in some extreme adverse our etiology. So what causes it? I kind of already said a little bit about it. On the top there, I have three of our major adrenal corticosteroids. So our glucocorticosteroids, got it, our mineral corticoids, and our androgens, okay? So these are what's really being affected here. So when they're reduced, our hypothalamic pituitary gland, some people refer to it as HPA, but I always forget that, to be honest. Our hypothalamic pituitary adrenal axis, specifically, which is basically our body's response to stress. Anyway, this affects the hypothalamus, our pituitary gland, and our adrenal glands. So you can see in my diagram there, those are the major sections that those three adrenal corticosteroids are affecting when they are being reduced. Let me think here. Oh, even anticoagulants. So we do have patients that are on anticoagulant medications. Those can also cause Addison's disease, autoimmune conditions, as I mentioned before. And I have here as well tuberculosis, AIDS, fungal infections, cancers, chemotherapy. So any kind of major trauma that's being done to our immune system that's going to affect those adrenal glands, these can all heavily impact the cause of Addison's disease. And like I said earlier, it is a very slow onset disease. It doesn't just come on immediately. It needs to be caused by something. And it's going to be prolonged as well, right? Next, we are going to go over our common signs and symptoms that we see with Addison's disease. Our next slide, I included some pictures and we're going to go through them as well. So common signs and symptoms, I'm going to start with our first hallmark signs and symptoms. It's basically hyperpigmentation and something referred to in our textbooks as our eternal tan. Some people also refer to it as the bronzing agent as well. So our eternal tan, our hyperpigmentation, I think we can kind of assume what it is. It's basically when melanin in our bodies is being overproduced and we get a nice like bronzy tan look. And with our hyperpigmentation as well, we'll see that really present in mucous membranes. So for nursing, when we're doing our assessments, we can do a little bit more thorough assessment if they're showing some other signs and symptoms. So other ones are like GI upset, so nausea, vomiting, diarrhea is also quite a big one. We have chronic fatigue, and this is also weakness in the body as well. And I don't have it mentioned here, but when I say chronic fatigue, I'm also thinking of muscle joint and muscle weakness, and also chronic pain that comes with that as well. I have it there, the abstract mucous membrane pigmentation. When I say abstract, I'm not trying to sound artsy. When we look at specific mucous membranes, so let's say our tongue or the inner part of our cheek, that's where we're gonna see clumps of like dark pigmentation. It's kind of a bad reference, but if we think of, let's say, a milk cow, those black and white spotted cows, that's what we tend to see in those mucous membranes, kind of like that sort of pigmentation. Not the pallor, the whiteness from like a milk cow, but those dark spots. And then we have some unexplained weight loss. Unexplained, I say that very sparingly. So since it's chronic and it's a very prolonged condition, and it's also a very slow onset, let's say over 3 months, a patient is not going to automatically assume, oh my gosh, I lost 1 pound this entire week. I have Addison's. No, so it's going to be prolonged over, let's say, like 3, 4, 5, maybe 6 months to like a year. We're going to see a drop in their weight, and that can actually be explained by their loss of appetite. With dehydration, it's also tied in with loss of appetite. We're not receiving fluids from a lot of things, especially if we have loss of appetite. We're not going to want to drink anything either. So we can also expect our sodium levels and potassium levels are going to plummet as well. And that's from both appetite and just from our hormones not functioning correctly. We also have, I have it labeled here as, I have it labeled there as discomfort. So we're gonna see actually like pain, itching, swelling, skin rashes. So although rashes and itching can be tied to a lot of autoimmune disorders and diseases, like for me, for example, I have eczema and psoriasis, and I have inconsistent patches of swelling, itching, and rashes on my skin. These are kind of dead giveaways for autoimmune conditions, and we can see that with Addison's because it is that. Oh, and orthostatic hypertension. I think I mentioned it earlier. You get up too quickly, that fatigue, that quick loss in blood pressure, you're gonna drop. Okay. Or it's quite prevalent. You can see it quite easily, okay? That hyperpigmentation, it's also easy to see in the cheek membrane if it's quite pale, paler skin type, okay? Obviously, the production of it is ever being overstimulated. When we see this in different patients, and actually that's my next, when we're dealing with patients that are identifying with a darker skin tone, let's say African American, it's not impossible to see that extreme hyperpigmentation. It's just a little bit more tricky. So where we want the areas of the body we're actually looking for is we're going to be looking at the elbows, ironically, I think because the skin is quite thinner, and we're also looking at those pressure points, so the back, the butt, the gluteal muscle. That's where we can see maybe some darker areas of their pigmentation. Even the inner part of their thigh, it might present a little bit darker toned than the rest of their skin color that maybe is more generalized, okay? And that's going to come with our nursing assessment as well. I'll talk about that later. Back to our implications for patient health and nursing care. Our stress tolerance. When you hear the word stress, when I hear the word stress, to me, I'm thinking of, oh my gosh, I'm stressed, I have so many things going on. That's not exactly what we're talking about in this case. When we think of stress intolerance, we are also thinking of like, oh my gosh, I have a lot of stress going on, because that can affect our hormones as well. We're also talking about the amount of stress that's our body is going through, okay? So I mentioned how the etiology, how we can contract Addison's, and I mentioned cancer patients. I also mentioned women can get it more often. So any kind of stressful procedure that is done onto the body, or any stress that the body's systems are going through, so attacking that negative feedback loop, that is something that the patient is going to be experiencing, right? Their body is going to feel terrible. We also have electrolyte imbalance. Loss of appetite and dehydration play into this. So Addison's disease, not only does it deplete our sodium, it also depletes potassium and stuff like that. So we'll get into this with the nursing interventions I'll talk about later, but there are different interventions we are going to have to do to help these patients maintain that. If you don't drink enough water in the day, you are going to feel terrible. Your body needs that hydration to go through all of its systems in order for it to act accordingly. We have hormone loss. That's something our patients can be going through as well. I explained it with women. We lose hormones, let's say estrogen, our body is not going to function correctly. Okay, we need to have homeostasis, those negative feedback loops, in order to bring our bodies back under control, basically. And also, if you're going through your day-to-day life and you can physically feel something's off, my hormones just feel off, I'm not feeling quite right, this kind of impacts with my psychological impacts as well. It's going to be very, very discouraging, you know. Hormone loss, this can also, in women, this can also fluctuate your menstrual cycles. So there have been cases and case studies where women, their cycles have either missed or they've been quite inconsistent, especially in postmenopausal women. Psychological impacts, I have here low self-esteem and anxiety. If your body's not working how it's supposed to work, I'm not going to feel okay. I'm going to be quite discouraged, you know. We all want a happy, a healthy life. If you're feeling quite lethargic, that GI upset, that nausea, loss of appetite, your joints are always hurting, that muscle pain, your skin is starting to change in ways that were just, it's quite concerning, obviously. If you see dark patches all over your skin, you're going to be concerned. Your anxiety is going to peak, and you're just going to wonder, why is my body not working the way it's supposed to? Okay, it's very discouraging for patients, and we need to really be showing them a lot of empathy in these times, and we have to do that in our entire nursing career also. All right, changes in care due to the disease. So there's not a lot of true major changes other than the fact of being more diligent in certain areas of our assessments and in monitoring, and we see that in different ailments as well. I actually just did a project on a urinary incontinence, and nursing interventions, they're not extremely different, but they're also, we need to be more anal on assessing and monitoring our patients, and the same goes for Addison's disease as well. It's just what we have to be more anal on specifically. So in this case, it's our skin assessments and our skin monitoring. So if we're having hyperpigmentation and we're having these bronzy tans, ultimately we're under production of melanin. This can affect our skin integrity overall. So ulcers are expected. Lesions are a really big one with Addison's disease. Patients are very prone to having lesions, and that's why providing proper patient education on maintaining good hygienic health is really big with Addison's. While they're in our care, let's say in a hospital setting, we need to really be monitoring their skin, especially in those mucous membranes, because that can be a giveaway for us, especially in documenting to see whether the pharmacological therapies have been working or not. Granted, it's not going to happen right away. So if we see a patient in a clinic or hospital in a specialist office over the course of a few months, and they're coming in for their different appointments, like check-in appointments with the doctor, when we do our assessments at nurses, if we look at those mucous membranes and we can see, okay, those darker spots, they're starting to pallor, they're starting to go away, they're starting to fade away. We can document, and we can also talk to the physician in charge of their care. This is our findings, this is our objective findings, that, okay, we can see our therapies are starting to work because those hallmark signs and symptoms, they're starting to depreciate. Fluid monitoring, this is especially important both in educating the patient when they go home and go about their daily life, but also while they're in our care hospital setting, we need to be checking those electrolyte levels pretty frequently and making sure that their IVs and they're getting enough they're getting enough fluids. And our medication management, when we do our care plans, obviously we're part of the care process, helping them pick the correct therapy that's just right for them and their lifestyle. Pharmacological, that is going to help maintain and manage their Addison's disease, mostly just the symptoms, just to help prolong their discomfort and hopefully alleviate that discomfort as well. With management, we're going to be seeing these patients. Everyone's going to have, just in general, everyone's going to be checking in with their doctor every few months to see if the new medications they've been on are working. And same goes for this. It goes with patient education. If something changes within like 2 weeks of starting this medication we're giving you, document it, write it down, or come in to see us, depending on their adverse effect that might come from it. You know, if we give them a medication and within like a week or two they're experiencing orthostatic hypertension, come see us. That can definitely affect your everyday life, you know. Cases, hypoglycemia is inevitably inherent in this case. But other than that, if anyone has any questions, please send them to me. I enjoyed this presentation. I hope you guys have a great rest of the day. And if this is just Tyler watching, hi. It's hard to figure out how to record myself, but I got it. Still don't know my rights from my lefts, but this is also my reference page as well. But have a great day. Bye-bye.